We want to be the region's leader in patient-centered healthcare. What's really exciting about Shore Regional Health is that we are extremely innovative.
My philosophy in patient care is that no one person can take care of an ill patient.
Shore Regional Health endeavors every day to innovate, to bring cutting-edge care to all the patients that we serve.
We're actually doing things here in Easton that only a few people, a few places in the country are doing.
We have a very caring and dedicated staff, from physicians through all the disciplines.
It is a sense of oneness with the community.
Creating healthier communities together can't happen without engaging your physicians in the process.
The Cecil Award recognizes physicians' contribution to innovation, to thinking outside the box.
It allows us to identify those innovative, creative, engaged, highly motivated physicians that really result in much better patient care on a day-to-day basis, and ultimately a stronger organization that's able to achieve our mission and vision.
In 1983, the Arthur B. Cecil MD Award was established to honor Dr. Cecil's contributions to clinical advancement and medical staff development. Named in his honor, Dr. Cecil was also the award's first recipient. Today, the Arthur B. Cecil Award for Excellence in Healthcare Improvement recognizes a physician or group of physicians who contribute energy, creativity, and effort to improve the quality of care.
We have become an organization that proactively looks at the sea change of healthcare that we're all experiencing. At Shore Regional Health, we are able to do that because we have great physicians.
My personal philosophy has always been collegiality and communication. Not only trying to learn, but also to teach, and also try to understand all the systems that are in play here. ICU patients require moment-by-moment monitoring. It is not a job of one physician, one nurse, one therapist. It is a collective approach to taking care of a patient. That's why multidisciplinary rounding is very important. All those players in the team to be together. Not only the healthcare workers are part of that team, but also families. We like to engage families, discuss the patient care and the goals of care with the family members every day, because the families know the patient more than we do, and their needs and desires.
When I think of Dr. Otmishi and what he has brought to Shore Health, I think of the quality initiatives he has worked on, preventing infection in the ICUs, his collaboration and education with the nursing staff and the rest of the interdisciplinary team, and then working with us to bring e-care to Shore Regional Health.
When we came here, there was only 3 of us that were on for an entire week. That can wear on you sometimes. And after discussions with the hospital and thinking about what is the best care for the patient, for the ICU patient, how can we have an intensivist available to the nurses and to the staff at all times? That's very important in community hospitals that don't have resident staff and fellow staff and teaching staff. What e-care does is the physiological status of a patient, for example, their blood pressure, their oxygen saturation, their ventilation, is continuously monitored by the e-care system to allow the patients to benefit from essentially an in-house intensivist who's not physically present.
24/7 having experts at the University of Maryland available by video and telephone.
All the rooms had to be set up with sensitive cameras, communication systems. The physicians can electronically monitor the patient through the e-care system. They have cameras that they can zoom in and look at the patient. And that also helps the nursing staff because they have immediate help at the reach of their hand. That also allowed us to have a little bit of break in the evenings because, again, that could kind of wear on a physician if you're on 7 days, 24 hours a day.
Dr. Otmishi has been very involved with a lot of interdisciplinary work around quality initiatives, which is really one of Shore Regional Health's strategic goals. He's been very involved with ventilator-associated pneumonia and central line bloodstream infection work We have gone over 5.5 years at Dorchester without a ventilator-associated pneumonia and over 4 years at Easton.
We are working together to standardize all of our algorithms throughout the whole system, including sepsis and sepsis response. So it is very important to have University of Maryland as a supporting system to our healthcare system here.
One of the important things in working with innovative physicians is making sure that they are good communicators, that they practice evidence-based medicine. They don't just go by what we've always done here, but what does the evidence show us is best standard of practice.
We have to deliver the best healthcare because we're the only ones that are here that are providing healthcare to our community. It is a sense of oneness with the community. People are very close, not only physicians, but the patients with the physicians. So that's why I enjoy coming to work every day and working with the people that I do. They're not only my colleagues here, my coworkers, but also they're my friends. That's why I enjoy being here. It allows me to be a part of that community.
I come from a family of physicians. My brother, when I was in 8th grade, had a need for neurosurgery. And at that time, the experience that we went through as a family strengthened what I wanted to do as far as neurosurgery. So since 8th grade, I wanted to be a neurosurgeon. So I walked around as an 8th grader telling everybody I want to be a neurosurgeon. Minimally invasive spine surgery is essentially doing the same objectives as you would want to do with an open operation. But how you get there is the trick. Instead of opening people up and destroying the muscles and the tissue, what you're doing is going in between the muscles with a tube, and you're literally operating through a tube about this size, and you're using more fingertips than you are using hands. So it takes the operation from an open, gross operation to a micro anatomy and microsurgery. You have to have understanding of anatomy way beyond the open operations because your landmarks are not there. And you have to imagine it in 3D without seeing it and understanding where the anatomy is and navigating your way through a very small opening. It's like trying to draw a painting only 1/4 size at a time, you know, and understanding what the painting is supposed to look like at the end. I'll give you an example. I did an 8-level fusion. That would have required transfusion, definitely, if I did it open. All these screws and rods were placed all through little puncture sites through the patient's back. And like I said, he lost 50 cc's of blood and left the hospital the next day. So this thing, to do it open, as you would imagine, you would have to cut from here to here and cut all that tissue. Blood loss, multiple drains, in the hospital for at least 7 days, and like I said, at least a few weeks in rehab before they can be discharged. It makes my service a lot better. I don't have chronic back pain patients. I don't have people in the hospital. My census is very, very low. I have 1 or 2 patients in the hospital at any one point in time because the majority of my surgeries are outpatient. 5% of surgeons in the country do minimally invasive spine surgery, and the ones that do only do the easier levels of minimally invasive spine surgery. The ones that do the levels that we do here in Easton are less than 5% of the 5%. We developed this modified approach to a single level fusion that has not been published before. And we did it on, you know, we recorded our data for 2 years straight. And we did over 80 patients, and the outcomes are mind-boggling and superior, far superior to anything that's published out there. And that's why our paper got accepted to the World Congress of Minimally Invasive Spine Surgery in Paris. The level that we're doing these things at now are so different and so unique compared to other people in the country. I get the best of 2 worlds. I get to serve a community and truly be part of the community. At the same time, I get to function at a high-level institution with ties to academic practice. I still go to University of Maryland. I'm faculty at Maryland. I still participate in resident training and publishing. So my career is not inhibited by the fact that I'm in the Eastern Shore. So when I was interviewing, my ideal locations were Hopkins, Maryland, Georgetown, and GW. This place called me and they said, hey, you're going to be close by. Can you come by here and check us out? And my wife absolutely loved it. And I said, absolutely not. And she said, absolutely yes. And so we ended up here. And I thought I wasn't going to last here more than 3 months. And quite frankly, it's been the best choice that I've made. And the reason is because I have utmost support from everybody around me here. The hospital administration, my colleagues, the physicians that are in the hospital, the physicians in the community that are referring me patients, the anesthesia team in the hospital, the radiologists, everyone just gathered around and supported me very well in my arrival here. And more importantly, the patients. I have never met a better, classier group of patients than the people from the Eastern Shore. It is unbelievable their appreciation for what you do. I can't get to a grocery store without having 10 people stop me. So it's a rewarding experience, and I'm glad that we're here. It's been the absolute right choice.
Dr. Kurtom and Dr. Otmishi's leadership is infectious.
You can't be the region's leader in patient-centered healthcare without having excellent quality.
We're very lucky to have physicians of this stature who are innovative and patient-centered living here on the Eastern Shore.
And one way that we can recognize those physicians who are engaged and who do participate on a regular basis is the Cecil Awards. So it all ties together.